Error. Electricity in line. Override accepted. Infusion initiated.
Welcome to the INS Infusion Room, the official podcast of the Infusion Nurses Society. In this podcast, we explore all things infusion therapy through a real-life conversation, covering the latest trends, new research, evolving standards, and key industry insights. Whether you're an experienced infusion nurse or new to the field, we aim to keep you informed and empowered with the knowledge to stay at the forefront of the profession. My name's Derek, and I'm your host. Let's dive in. Hello, and welcome to another episode of the INS Infusion Room. Today, we're going to talk everything about product implementation and how to make you successful at the bedside. So today we have Mike Whitner joining the studio. I do want to make mention that BD is our sponsor for today's episode. Michael Whitner is the Director of Clinical Transformation with BD. The speaker is an employee of BD, and any discussions regarding products during the presentation is limited to information that is consistent with labeling. Please consult product labels and inserts for any indications, contraindications, hazards, warnings, cautions, and instructions for use. Mike, to get us started, would you give us a little bit about your clinical experience and or professional experience?
Thanks, Derek, for having me. Very happy to be here. So I've been a nurse for almost 15 years. 2019, I joined BD, but prior to that, I had some ED and trauma experience. Also was an interventional radiology patient care coordinator. That is where my true passion for vascular access began. I also ended up placing some PICC lines as well as midlines and other vascular access devices in LTACs and rehabs. And then also had some experience starting a vascular access team and being a vascular access team lead for a few years, growing that team, and then promoting that one facility team to have more of a system-based model, which is kind of what brought me into the world of BD in 2019, like I had mentioned. In BD, I've had a few roles in vascular access, specifically in our MDS division. I've also had some roles in our US region or enterprise. And now, actually, most recently, I am back in the business specifically for vascular access. So again, thanks so much for having me.
Yeah, thank you so much for joining us. So there's lots to unpack here around implementation. You know, sometimes we see implementation and it looks good on paper. We have a really wonderful roadmap, but we do run into those barriers as we move forward with that. So to get us started, when you think about back to your first major product rollout, what surprised you the most about the process?
Yeah, that's a great question. So I can immediately think back to my first days as the vascular access lead at a facility in 2016 when they had just rolled out a brand new to them peripheral IV. And as we all very well know on this call, especially, PIVs are in every aspect of a facility across numerous disciplines. And what surprised me the most was how much an individual can have an opinion on something as small as an IV. And because of that opinion, how fast things can travel to senior leadership. I mean, I was again the first week of my role and hearing all about this IV, and I was really just trying to learn who everybody was, let alone thrown into a conversion process. And so at that time, I did report to the CNO, and she immediately called me into her office and said, "Well, I think the first thing we're going to have to figure out is this peripheral IV together." And so for me, it brought a lot of perspective on how quickly a dissatisfier can get to the chief of nursing and how it can be quite a focus for an entire facility for quite some time.
Really great point. So within that, you had those barriers. What were early signs that this implementation that you're talking about was going to experience barriers?
Yeah. So some of the barriers were specific to the amount of support that was being provided. And I think also an awareness as to why the IV was chosen. And I think the messaging is extremely important because often we do seem to think anyway that a conversion or product is chosen because it must be the cheapest thing out there for that facility. And that's not always true. And in this instance, that wasn't true. There were certain reasons why this product was chosen, but I think that some of the barriers early on were that there were physicians and anesthesiology groups that weren't really made aware of the change. There were some nurses that felt as though they weren't brought into the fold per se, or been heard, or been part of that decision early on. And so there was a lot of rumblings as to, well, this is something that we're just kind of being told to use, rather than potentially something that would be beneficial for both the clinician's use as well as patients.
Yeah, it sounds like much of the groundwork happens before the product even arrives. How do you build that foundation of trust and alignment early on?
Yeah, definitely. The preparation of any of these conversions is, in my mind, almost 90% of the work. Once we get on the ground and are actually in active conversion, educating on product and getting product on shelves, that's when there really should be smooth sailing if we've prepared the appropriate way. Um, some ways to build foundation of trust and align kind of early on would be what we call cadence calls with senior leadership, mid-level, and bedside. You need that interdisciplinary team to truly understand the why as to how we're going to be moving forward with a certain product. And everybody needs to be heard. The voice of that clinician at the bedside, along with the interdisciplinary team, potentially of educators, of leadership, quality, infection prevention, and physician groups, all need to come to the table ahead of time to be able to voice their opinions. And so we understand where everybody's coming from. So then when they actually get the product in hand, they understand that, and that trust and that foundation and that environment of psychological safety has really been kind of brought forward. I think one last piece is being transparent and being relevant. And we need to, as I said, be heard, but we also need to bring relevance to the conversation. There are often clinical, financial, and operational reasons as to why a product is being converted. And there needs to be a level of transparency from senior leadership, mid-level leadership, as well as clinicians to be able to promote this product conversion in a way that the messaging is impactful for everyone involved, including the patient.
Yeah, great point. And when we're looking at change or implementation, I think it can come from different directions. It can come from a request from a clinician, or it could come from the other direction. So, if it's coming from the direction of senior leadership or leadership promoting this change, how do we prepare clinicians for change? What are some of the most effective ways that you've found to support nurses and clinicians during the product alignment or product transition?
Yeah. Again, if it's coming from senior leadership, I often find that the senior leaders that are the most involved at the bedside and have the best perspective can also bring forward the most interdisciplinary team, and in turn be most successful in a sustained change. What I mean by that is senior leaders, they need to promote that flexibility. And so clinicians need flexibility, especially the clinicians that are going to be involved in this process. There needs to be a lot of listening. We need to do listening to I've said concern, but also vice versa. The bedside clinician needs to have that kind of open mind. And I think, at bedside as a nurse, and honestly, just as a human, a lot of times we don't really like change all that much. And so we really need to understand where everybody is coming from and respectfully and professionally be able to challenge when appropriate. That doesn't mean to be authoritarian or, have dictating rules, but have that gentle pushback when appropriate. There's times when a bedside clinician may be speaking from emotion, a leader may be speaking from emotion, and we need to try and have that kind of high level of emotional intelligence so we can promote that environment to effectively support everyone in that transition.
So, with communication being at the core, how do you ensure communication stays clear and consistent across teams, and especially with your larger organizations?
I think it's important to understand the processes that have worked in the past in your organizations. And it's also important to understand the barriers that you have had. It's also important to understand how people want to be communicated to. So, if you're a bedside clinician, do you always have time, or are emails always the most effective way? I've heard it's not. However, I do understand that some levels as leaders are always communicating via email. So I think it's important to understand what works. And again, kind of going back to the initial questions, having that environment where we're transparent, where we're trusting, and where we're able to discuss with everyone how we want to be communicated to. I think it's also very important to understand, especially now we have enormous, I say enormous, healthcare systems spanning the country, spanning multiple states, multiple regions and geographies. And as that happens, all of those organizations may have communicated in a slightly different way. And when they come together, if there's not been harmonization, we find that there's barrier in communication because of all of those different ways of communication. I think it's really important to lean on your industry partners and again, your system level leadership to understand how we're going to communicate this change to the entire organization in a succinct way, and understanding that semantics do matter and what we call something does matter. And the reason I say that is, let's use, for example, a change of a connector. If I say connector, people might say 3 or 4 different things. If I say a cap, that might mean a million things. If I say a hep lock, getting there. If I say a clave, maybe. A needle-free connector, okay, now we're getting closer. But if everybody is calling this needle-free connector, which is what I'm using the example of, something different, we may have a myriad of different types of questions that aren't even appropriate for the actual product being converted, simply because we haven't all used similar language.
Yeah, I think those are solid points. So I have another good question for you. How do you balance the technical training with the cultural and emotional aspects of change?
Yeah. Well, first of all, empathy goes a very long way in life, any aspect of life, once again. However, when you are kind of balancing that technicality and the culture, you need to have that listening ear. A lot of times it's, I do understand your concern. I hear you. Can I ask a clarifying question? When you are invested in the individual that you're speaking to and you share your own flexibility and that you are truly trying to understand where those individuals are coming from, the technical training just falls into place. Once we have the trust and that high level of emotional intelligence, once again, during this process, is when that technical training can then occur and become much more conversational and very simply educational rather than potentially a confrontation.
So to put this in real life, do you mind to provide an example of a challenging implementation, just to give our listeners a real life understanding of what some of those challenges could be?
Definitely. So, when we speak to product conversion holistically, it's truly change management. And how are we going to either freeze or unfreeze, potentially pivot and stray from that timeline that we may have had, in the past, and now we need to change something, or it might be in the form of a group of clinicians or a unit in the facility, or maybe a group of physicians. And so one example I have is that I love anesthesiologists. Do not get me wrong. I wanted to be a CRNA in nursing school. They are a crucial part of our healthcare system, but they do sometimes have an opinion. And so this group of anesthesiologists was very difficult to work with, but also to even get time on their schedule to show them the support that they needed. And so it was a large conversion, and we had quite a large group of anesthesiologists across a geography that all had a very negative feeling about the conversion. And so
Not a good
this
place to be.
it wasn't the best place to be. It felt like a penalty box, I will say. However, in working through it with the anesthesiology leadership, as well as some of their coordinators, we were able very quickly to lay out a plan to show them that A, their voice would be heard. B, we were able to offer whatever support they needed at whatever time was beneficial for their extraordinarily busy schedules, which I say that because they are so busy all the time. And we shared what we were going to speak about and that it was going to be an open forum as well. And we also understood that we had about 5 to 7 minutes to accomplish all of this.
Oh,
So I think it's leading some ground rules, and some being proactive as possible, but understanding that there's going to be some blips on the radar, right? And these obstacles that we have to pivot. Eventually, we ended up talking to, I think it was 50 to 70 or so anesthesiologists across multiple geographies.
wow.
And every opinion they had was valid. And I would say vast majority was answered within the first 30 seconds to 1 minute of actually just having that conversation. So, we talk a lot in healthcare and change management about having those crucial conversations and ways to approach crucial conversations. And I did just outline one way to do that. And at the end of the day, this outcome was positive. We found that there were very specific areas in the anesthesiology group that did need a slightly altered type of product, which was offered to them, but the vast majority could use the device just as they were. They just needed to have that time to voice their opinion, to be heard, and then to ask questions.
What advice can you give clinicians who are feeling overwhelmed during a product implementation or process?
Yeah, no, that's a great question too. Often, once again, in change management and product conversion, we do encounter frustration. And I think it's really important to, again, promote that environment of psychological safety. And I said that prior, but everybody needs to feel heard. They need a safe place to be able to debrief or express that frustration. Ways that we would approach that would be potentially for that frustration to actually happen literally behind a closed door or in a safe space where they're not going to have potentially their leadership and management and coworkers to hear their frustration, because a lot of times we don't, as humans, want that publicized, but we do need those individuals to speak their mind and to have that place to feel heard. So I think providing that place behind closed doors is step one. But I think step two in that process is to continue to follow up with that individual. It's not a transaction typically, it's a support. And we want to be proactive and sustaining with that individual or those individuals that are most frustrated, because they may have a new frustration that comes up a little further down the road, and they know that they have a resource or support now in an individual, and we can continue that process to help and decrease their frustrations so those frustrations don't trickle over into other units or coworkers and grow.
So, shifting gears a little bit, after a new product is implemented, how do you sustain that momentum and ensure adoption continues over time?
Yeah. So, follow up, I mentioned, is extraordinarily important, but with the individuals that are frustrated, but in general. And so I think in the thoughts of a conversion of a product, especially one that may be impacting an entire facility or health system, it's important to have a timeline of how and when and where and who is going to be involved in the conversion process. And part of that conversion process is follow up and the proactive follow up before we even get product on shelves. Let's get on the books when we're going to be back. You know, let's hopefully get to the point where we don't want to talk about this anymore because it's just part of our new culture, right? It's how we're going to move forward with improving the patient care. We also want to make sure that momentum is sustained through collecting measurable data. Regardless of product, there's something you're going to be able to collect. And I alluded to the fact that we need to know clinically, operationally, and financially how this device or product is going to impact our clinicians and patients. But we need to be able to show measurable data in those three categories in order to have the largest impact with our audience that we may have in the future that may be questioning why we have a certain product. I think lastly, it's very important to understand what initiatives and goals your facility is trying to accomplish. A lot of times, large healthcare systems have strategic plans, and within those strategic plans, which are years long, they will have nuances and tactics on how they're going to reach those goals. If we can get to a point where product conversions are impacting patient and clinician care, and we have measurable data that we can provide that shows that we're helping to meet those initiatives or goals, potentially at a facility, or a health system level, that's when you're going to have that sustained change and continued momentum.
Well, thank you, Mike. And I got one final question for you. This is a surprise question.
Okay.
Um, but if we have any listeners that are clinicians at the bedside and they're really hoping for an additional tool or change that's going to have better outcomes for their patients, what's the number one advice you can give them to make that change occur?
Well, that's a great question. Um, so I think it is, we did kind of answer it already, but the number one piece of advice is to have a strong interdisciplinary team. And when I say interdisciplinary, I mean, yes, within nursing, but also outside of nursing and infection prevention, quality, leadership. You need to have those individuals on your side throughout this entire process. And it needs to start from the very beginning with that interdisciplinary steering committee that you may put together or gain momentum initially with. So you can move forward with the process, but also so it can be sustained.
Well, thank you, Mike. And I really appreciate you joining us today in the INS Infusion Room. Any final thoughts before we end today's segment?
No, when Derek asked me about this subject, though, I was extremely happy to speak to it. It's a passion of mine, something that I've seen from the bedside, from a clinical educator, and then also from a leader. And so it's interesting perspectives when you speak to various levels of clinician within facilities that have been a part of one of these large changes, and if it was a positive or a negative experience. And our goal is for it to be as positive as possible, but we always are going to learn from those potential barriers or obstacles. And those frustrated people are often what make us stretch the most and grow. So I always say I like to live a little bit in uncertainty and uncomfortableness. And I think that these conversion processes, every single one of them is slightly different. And it's always an interesting topic to talk about. So thank you very much.
Well, thank you. And as always, I'm your host, Derek, and it's been a pleasure sharing this important discussion with you. Remember, knowledge empowers us to make informed decisions. Until next time, stay informed, stay curious, and keep gaining knowledge. Thank you for tuning in.
Infusion complete.